Hello, my name is Mowlni and I am a final year dental student at the University of Sheffield and a dental elementary ambassador. The notes for this presentation are a combination of what is on the elementary website, my lecture notes, and SDCEP guidelines. So, what is sedation? Well, in routine dental practice, we give local anesthetics for extractions. However, sedation is used as a management technique for pain and anxiety in children and usually for nervous adults. Conscious sedation aims to make patients feel relaxed, lightheaded, tingly in the hands and feet, and floaty. General anesthetic is an unconscious form of sedation and usually puts the patient to sleep or is a form of deeper sedation. Conscious sedation modifies patients' state of mind and allows communication and response to commands. This essentially reduces the systemic vascular resistance, or SVR. The heart pumps against resistance. Therefore, with addition of sedative, there is a reduction in perfusion resulting in lower SVR and cardiac output. It is important to establish a good safety margin so that consciousness is maintained and airways are protected. The most common techniques used are inhalation sedation, in which you should expect to see the patient awake, feeling relaxed, giggly, respond to verbal commands, and maintaining mouth opening. SDCEP guidelines suggest inhalation sedation with nitrous oxide and oxygen as the only standard technique for more cooperative children. Oral sedation is another commonly used technique using midazolam, which is a benzodiazepine. Other techniques include intravenous sedation, which I will be discussing in depth later on in this presentation, nasal and transmucosal sedation, and intramuscular sedation. Some of the opioids used for combination drug therapy are fentanyl, remifentanil, and morphine. However, we want to avoid polypharmacy as it can reduce the effects of the first drug administered, or there is a greater risk of overdosing or oversedating the patient, which will lead to hypoxia and coma with reduced tissue perfusion into the heart. The most major risk is death from GA, or general anesthetic. Hence, conscious sedation is opted for. It is always important to assess whether the patient is suitable for sedation within a dental practice using the ASA grading system. ASA grade 1 and 2 patients can be treated within practice as they are healthy or have a mild form of the disease, respectively. ASA grade 3 and 4 patients have severe systemic disease. Grade 3 is poorly controlled diseases, whereas grade 4 are ongoing diseases. Hence, these patients will need to be referred to the hospital. In this table, I have summarized the indications and contraindications of inhalation sedation. Examples of indications include needle phobia, mild anxiety, or conditions aggravated by stress. Discussing the medical contraindications in depth, patients having blocked nose means they cannot nose breathe. Patients with COPD have high levels of carbon dioxide and low levels of oxygen. Methotrexate has an antifolate effect and the risk of folate deficiency. Patients who have had previous intraocular surgery should not have nitrous oxide sedation, as this diffuses into gas bubbles, causing blindness. Inhalation sedation is not recommended for patients who have severe anxiety. Some advantages of inhalation sedation include no needing to fast. SDCEP guidelines states that fasting should only be monitored if the patient is at risk of aspiration. Usually, this is 2 hours for clear fluids, 4 hours for breast milk, and 6 hours for solid foods. The drug levels can be easily altered for a maximum exposure of 100 parts per million over 8 hours of nitrous oxide. And therefore, there will be minimal impairment of reflexes. One disadvantage of nitrous oxide is its lack of potency, as it is volatile, denser than air, less potent, and is poorly soluble. I have listed some important facts about nitrous oxide for sedation. It is important to note that a maximum of 70% of nitrous oxide is delivered. Nitrous oxide is titrated to get effective conscious sedation being 10% per minute to 30%, and then 5% per minute until the patient is sedated. Oxygen is delivered at a rate of 5 to 6 litres per minute throughout the procedure. One safety feature of the inhalation sedation machine is the oxygen failsafe, whereby once the oxygen stops working, the nitrous oxide will also be cut out. The oxygen flush valve is also important to deliver 30% of oxygen per second when the patient undergoes deep sedation or in an emergency to wake up the patient. Diffusion hypoxia occurs when oxygen is not delivered at the same time lungs are filled with nitrous oxide. This does not cause death, but causes difficulty in breathing. Therefore, oxygen must be delivered at the end to dilute the nitrous oxide for at least 3 to 5 minutes. Nitrous oxide also has analgesic, anxiolytic, and hypnosis effects. Anaesthesia is used in conjunction with nitrous oxide. According to the SD-CEP guidelines, for adults having had inhalation sedation operation, there is no need for adults to have an escort unless they have mobility issues. For anything other than inhalation sedation with nitrous oxide, ensure there is a responsible adult escort after treatment, and this includes the general anaesthetic and intravenous sedation. If the patient is sedated later in the day, then the escort will have to stay with the patient overnight. However, in general, ensure the patient does have transport facility. For children, ensure they are accompanied to the appointment and back, and their siblings are not with them. Other preoperative instructions include warning of dizziness, nausea, and headaches at higher doses. Also advise the children to take routine medications. Record keeping is important for inhalation sedation. It is important to keep a record of the patient's consent and escort. The safety checks are completed and attached. Noting down who assisted the dentist, mask size, flow rate, maximum dose, response or level of consciousness, and recovery time. This is essential for all sedation. So, moving on to intravenous sedation. This is a cannulation route which allows direct access to the venous systems of patients and allows administration of drugs. The ideal site is the antecubial fossa or the dorsum of the hand. Some of the specific veins to look out for are the cephalic vein, median cubial vein, and basilic vein. A tourniquet helps to visualize the vein better. Venipuncture may also occur, resulting in transfixation, hematoma, and embolism. There is also the risk of intra-arterial access. So in this case, you will have to contact the local vascular surgeon and ensure that you keep the patient warm and monitor them. The drugs administered for intravenous sedation is midazolam, and this is injected and saline is flushed out. Midazolam can be used for patients who are 12 years and older. Propofol is also acceptable. Midazolam is a type of benzodiazepine that takes 2 minutes to become effective with an initial dose of 2.5 milligrams. 200 micrograms of flumenazole should also be given to reverse the midazolam effect every 1 to 2 minutes. A lot of assessments are carried out during the intravenous sedation process and for other sedations as well. This is an exhaustive list, so it is good to note them down and the normal values that you should be looking out for. Baseline physical assessments are carried out, which includes medical history, dental history, BMI, and ASA assessments. With sedation, we will hear more shallow breathing. Therefore, as carbon dioxide receptors are being reduced, there may be complete cessation of breathing. Therefore, be aware of carbon dioxide narcosis. Hence, capnography is also useful. Patient may also feel hypertensive due to vasodilation, due to the sedative drugs, and therefore there will be a reduction in contraction of the heart. If this happens, treatment will need to be stopped immediately and intravenous fluids administered. For this reason, the patient's weight should be acknowledged beforehand and their fasting regime. Throughout the treatment, you should monitor the patient's color, pulse, blood pressure, and capillary refill. 15 litres per minute of oxygen should be delivered in an emergency, hence pulse oximetry is also important, and oxygen should be on site in the intravenous sedation treatment room. There is also the chance of the patient going into cardiac arrest, in which case the BLS CPR should be carried out. We know there will be reduction in the tone of muscles with conscious sedation. This can lead to upper airway obstructions. Signs include snoring, stridor, drop in oxygen saturation, loss of carbon dioxide trace, and seesaw respiration with abdominal muscles exerting more to breathe. If these are not treated, the patient may lead to respiratory failure. Patient must therefore be treated with supplemental oxygen, and in this case, the basic airway maneuvers with head and chin tilt lift and airway adjunts. The patient is advised against IVS if they have respiratory depression, poor veins, have an allergy to benzodiazepine, acute pulmonary insufficiency, sleep apnea syndrome, and severe hepatic impairment, to mention a few. Once the patient has had their treatment, the patient may be discharged from the hospital an hour after their last intravenous midazolam dose. It is essential that they receive a written and verbal postoperative instructions, and they have an escort. The escort will have to take care of them for at least 24 hours. Check that the patient is steady on their feet and that they can walk before you discharge them. Furthermore, for 24 hours, the patients are prohibited from carrying out any legal work, drinking alcohol, and carrying out household activities, for example, cooking and ironing. Oral sedation uses midazolam 0.3 to 0.5 milligrams per kilograms. This is useful as it is simple to administer. It has a predictable action and duration and low incidence of side effects. However, it does take up to 40 minutes for full effect and effective for 30 minutes before recovery for 30 minutes. Nervous patients may take diazepam or temazepam prior to surgery. Nasal or transmucosal sedations can be carried out sublingual, rectal, and intranasal. Midazolam is used like a nasal spray, and the main advantage is that there is no venipuncture, as we find with intravenous sedation. Due to the bitter aftertaste, it is not commonly used in pediatrics and will require good patient cooperation. Finally, general anesthetic, or GA, allows for a state of complete unconsciousness. The patient cohort are usually young children, families with a high caries rate, families from socially disadvantaged backgrounds, and parents with little motivation and control towards diet. As we know, midazolam works on the GABA receptors to cause sedation in the brain and inhibits the receptor. In general anesthetic, when midazolam works with barbiturates, there is an increase in the effect of sedation. As already mentioned, children with management problems usually have treatments carried out under general anesthetic, but also patients with learning disabilities or have had orofacial trauma, acute facial swellings, and patients with hemophilia. So, on the day of treatment, when a patient is having a general anesthetic procedure, double check that there is a necessity for the treatment, ensure there is a clear treatment plan, informed and valid consent is obtained, all records are available, details of medical status known and anesthetist informed, fasting times are observed, escort requirements are known and observed, and the child is fit and well, so therefore they do not have a cough. Thank you so much for listening to my presentation, and I hope you've enjoyed it.